Thank you so much. First of all, I would like to thank the Bangladesh Cardiovascular Interventional Society for their very kind invitation. My name is Nazmi Calik. I am working as an interventional cardiologist in Istanbul, Turkey. In the next 10 minutes, I'm going to introduce and present one of my worst nightmares in the cath lab. My case is a 51-year-old gentleman. He has presented to our emergency service with 2 hours of typical chest pain, and his hemodynamic was stable when he presented. In the ECG, as you can see, there was an ST elevation in the inferior leads and with the reciprocal changes in the opposite leads. And we loaded aspirin and prasugrel and head to the cath lab. In the baseline coronary angiogram, the left system was normal, but we had the subtotal occlusion of RCA in the middle of RCA. As you can see, this was an eccentric stenosis, which deserved a recanalization. At this point, maybe we can ask to the audience about the stent size. Which stent size would you choose in this particular patient? Who would go for a 3.0? And who would opt for a 3.5? 3.5, 3.5. Who would go for a 4 millimeter stent? 1. Okay. We opted for a 4 by 18 millimeter drug-eluting stent, and we inflated it at a nominal atmosphere, but as you can see in the right-hand side, the coronary artery, the RCA, was ruptured after the stent balloon inflation. And this was very compatible with the widely known Ellis type 2 classification, perforation classification. So how we manage? The first thing while managing perforation is the inflating the stent balloon at the rupture, at the perforation site. As you can see from the first catheter, we did advance the balloon of the stent and we inflated at the rupture site. And we decided to proceed with a ping-pong technique, which is also called block and deliver technique. And this case was happening, one of the worst part of this case was happened while I was on call. After inflating the balloon in the perforation site, we did another second access from another arterial access, and we did advance the second guiding catheter. After this, the second move in this technique is to moving back to the first catheter and engaging the second catheter to the RCA and advancing the guide wire just proximal to the inflated balloon. After deflating quickly, you can advance the guide wire distal to the perforation site, and then you have to inflate quickly to prevent bleeding. In the next step, after moving the first guide wire balloon and the first guide wire, you just open your graftmaster or papyrus cover stent over the perforation site. As you can see, perforation is completely sealed in this scenario, in this particular patient. And after a protamine administration, the patient was transferred to the ICU, but our nightmare wasn't over yet. After 30 minutes, the patient had another recurrent chest pain and ECG changes. When we took him to the cath lab again, we saw that probably because of the protamine which was administered, the cover stent was occluded. And after an NC balloon, this was pretty straightforward. We did achieve the TIMI-3 result. While during the ICU follow-up, we did a very limited pericardial effusion, which was totally gone before the discharge, and the ejection fraction of the patient was hopefully preserved. And the medical therapy before discharge was included aspirin, prasugrel, ramipril, metoprolol, and atorvastatin. The coronary perforations can be classified following their location. They can be, as in our case, they can be large, proximal, or smaller distal perforations. Even in the CTO, epicardial or septal CTO interventions, you can see the perforation of the epicardial or the septal collaterals. And per severity, the Ellis classification is widely used, and our patient had a class 3 severe Ellis perforation. You have to have your cover stand at your shelf while if you are doing PCI, because perforation can happen anytime, and you have to know your cover stands. The most widely used two cover stands are the Papyrus and the Graftmaster stands. I can only say that from this slide, the Papyrus stand is much more user-friendly and much more easy to deliver. This is a universal algorithm for all type of perforations. First, as in our case, you have to inflate the balloon. You have to give intravenous fluids. You have to be prepared for the pericardiocentesis, and you have to call the surgeons. And if your perforation exists persistently, you have to deliver a specific, type-specific treatment. And for the large vessel perforations, as we did in our case, you can use a cover stand, you can use a prolonged balloon inflations, but for the distal vessel perforations, you have to embolize the vessel distally. You can use fat or coils for this specific type of treatment, or you can just put a cover stand over the perforated branch origin. If you have still continued extravasation, you can reverse anticoagulation at this time after you remove all the gear you have at the coronary territory. And if you can't still sort out the problem, please do not hesitate to call the surgeons. My last slide, my take-home slide for this session includes a 4S rule for the management of coronary perforation. If you have a coronary perforation in your cath lab, please maintain a stable emotion and keep the guiding catheter or guide wire stable. Second, be smart, don't panic, don't yell to anyone in the cath lab, and try to keep a cool and smart head. Please do not be late for putting a cover stand, particularly for the large vessel perforation. And please do not try to save the day by yourself, and please do not hesitate to call the surgeons. Thank you so much for your attention.